Good morning, and thank you all for joining us. And a special thank you to Nadine Price for being here to present today on Fluorescence Imaging is an essential tool of DFU management, a 2-year analysis of outcomes and cost savings in a hospital outpatient clinic. Now, after her presentation, there will be a short Q&A, so please find the chat icon and put any questions that you may have for Nadine into the chat for this call, and we'll try and get through as many as we can. And I'll now turn this over to Nadine Price, who is Care Pathway Lead for Acute Podiatry at Whipps Cross Hospital in London, part of the UK's National Health Service. Good afternoon, Nadine, and thanks so much for being here.
So thank you so much for having me. Good morning, everybody. Hope you're enjoying the conference. As Nick said, I'm Nadine Price. I'm Care Pathway Lead for Acute Podiatry based at Whipps Cross Hospital with the North East London NHS Foundation Trust. And I'm here to just talk you through some of our findings and experience in using the MolecuLight over the last couple of years. So on the next slide, I think there are just some disclaimers. I'll just leave that for a couple of seconds. Okay. So in our department, annual antimicrobial dressing expenditure is our biggest variable cost, and we're always keen to get these costs as low as they can be without compromising on patient care. So the NHS as a whole, we spend almost 970 million a year treating ulcers and any related amputations, and a lot of the cost is driven by the wound healing time. So we know that the longer a wound is open, the more resources are required to manage the wound, and the more chance there is that it's going to become infected at some point in time, which ultimately results in poorer outcomes for the patient and also higher costs for the healthcare system. So, on to the next slide. To effectively treat wounds, we need to be able to accurately detect whether there is clinically significant bacterial burden present in the wound. And although we usually rely on the clinical signs and symptoms of infection to inform our decision making, these criteria are often non-existent or challenging to detect, especially in my field with diabetic foot. Patients often don't have very good circulation or they have neuropathy, and these can mask the typical signs and symptoms of infection that you might otherwise expect to see in normal wounds. So with the point of care fluorescence imaging, it presents an objective method of reducing the diagnostic uncertainty of bacterial burden in a wound. So in the images which are produced by the device, the presence of red or cyan fluorescent bacteria indicates clinically significant levels of elevated bacterial burden. And there's been several clinical studies of which are shown now the handheld device can improve the detection of wounds with high bacterial loads. Into the next slide. So as I said, in the NHS, we're always keen to evaluate opportunities for cost savings and improving patient care. And I started this work wondering how, once we'd incorporated the objective imaging technology into our routine wound care, I wanted to know really if this had impacted on my antimicrobial dressing use and also whether it had any impact on wound healing. So I decided to run a retrospective study just to address these two questions. Next one. So for the analysis, I compared antimicrobial prescription and wound healing data from 2 time periods. Year 1 includes information collected prior to the implementation of the fluorescence imaging procedure. And during this time, patients received the standard of care for diabetic foot ulcers as per NICE guidelines, which we're obliged to follow here in the UK. And year 2, the second year, includes information collected after we added the fluorescence imaging procedure to our routine clinical assessment. If we go to the next slide, you can see some of the results. So you can see in the year prior to using MolecuLight, 85% of our patients were prescribed antimicrobial dressings and 2/3 antibiotics. In addition to this, we observed wound healing rates of 39%. In the year after fluorescence imaging was introduced, we saw a 49% reduction in antimicrobial dressing use, along with a 33% reduction in antibiotic prescriptions. This reduction occurred despite a 23% increase in wound healing rates. On to the next slide. So before the fluorescence imaging procedure was introduced into the clinic, the total antimicrobial dressing expenditure per year was about £2,300. In the 12 months after fluorescence imaging was introduced, the total antimicrobial dressing expenditure fell by 33% to £1,531. And this reduction occurred despite a 27% increase in the number of wounds seen in the second year. To account for the difference in the number of wounds treated over the 2-year period, the antimicrobial spending was normalised to the total number of wounds assessed, and we found that per wound, the antimicrobial spending fell by 47% from £22.68 to £11.96. If we move on to the next slide. So wound healing rates are impacted by many factors that contribute to the total cost of treating foot ulcers. To estimate the impact of the routine fluorescence imaging on our total annual wound care cost per patient, we applied the healing rates we saw in year 1 and year 2 to the known costs of patient care reported in a 2018 study by Guest et al. In the retrospective analysis, they analysed data from 130 diabetic foot ulcers across the NHS to determine the average cost of care for a foot wound over a 12-month period. They found the average cost of treating an ulcer was £2,138. Treating an unhealed foot ulcer was almost 4 times as high, and treating an amputated foot ulcer was almost £17,000. So these varying costs were multiplied by the healing and amputation rate data that we observed over the 2 years. And we found that the total cost of wound care based on just standard of care alone was estimated to be around £7,662 in the first year. With the addition of the fluorescence imaging in the second year, we saw a 23% reduction or increase in the wound healing rate, which amounted to a total cost of £6,900, with an estimated cost saving of £762 per patient. So the results of this study have led to an additional 12 devices now being used across our trust, and it's effectively becoming the standard of care for our more complex wounds. Okay, so if we move on to the next slide, I can just show you an example of image-informed care. So this is a patient with type 1 diabetes who presented with an ulcer on his left that you can see around the periphery of the wound, which shows the elevated bacterial burden. So I use this guidance to take a tissue sample from the region of the red fluorescence, which one process confirmed the presence of multiple wound pathogens. And it's a really good example of how you can use the MolecuLight images to guide your wound sampling to the area with the highest level of bacterial burden. Okay, and just on to the next slide. So looking back, one of the biggest things I've learned since using the MolecuLight is that a picture really can tell us 1,000 words. There have been so many times where I've looked at the wound and thought it looked okay, and then taken a picture with the MolecuLight and realised that actually, no, maybe it's not okay. And it's prompted me to do more debridement or more investigations and just treat that wound slightly differently to how I would otherwise have done. I think it's really useful for getting my patients involved and engaged in their care, and I really don't think you can underestimate how valuable the MolecuLight is as a tool for that. Also, from my point of view, and in my practice certainly, the cost savings that we've seen have been really, really positive, and making these savings then allows us more flexibility within our budgets to do other things that we want to do. So yeah, thank you very much for listening to me today. I hope you found it interesting, and I'll hand back to Monique.